All right, everybody, welcome back. We're going to talk about neurodevelopmental disorders today. And some of you just finished watching the developmental disorder about the presentation about cerebral palsy and spinal bifida. Um, for those of you who are watching these back to back as part of a class, this is going to be these are going to be kind of a little bit long. That one went a little bit longer than I wanted to. So I'm going to try and move through this pretty quickly at the expense of talking about some of these important topics that we're going to talk about, as you'll see here in just a second. We're going to talk about all these things: intellectual disability, the autism spectrum, ADHD, and specific learning disorders. And I am absolutely not going to do justice to this. I was complaining in the last one about how there was a slide, vocational implications, and that's like what rehab counselors do, and there was 2 bullet points, which means it was not adequate in describing all the vocational implications. And these are going to be the same thing, kind of, that I'm going to have to breeze over some things really quickly, but it's because of timing and whatever. So if you're watching this as part of a class, there's going to be a textbook, and there's more to read, more to learn. And if you're seeing this some other way, then just know that if you're sitting there screaming at the screen, saying, he's not telling it right, and there's more than that, and this is not enough, and I'm right there with you. I'll just be, as I smile and laugh on camera, when I get off, I'll just like kick the chair or something to show my frustration. But anyway, this is what we're going to talk about today. As opposed to developmental conditions, which we talked about CP and spina bifida being kind of like neurological, musculoskeletal, that kind of stuff. Now we're in the realm of neurodevelopmental disabilities, meaning things that are going on in the brain. And this is the stuff we're going to talk about as just sort of a general category here. The big umbrella, I guess we could say. So we talk about intellectual disability, we're talking about a really large umbrella. Sometimes we use the term generically to mean, let me go back actually. Sometimes we're using the term generically to talk about all these different things, like I just did. In the case of the next slide, what we're talking about when we say intellectual disability is a very specific thing. In other words, there is a case to say that autism is an intellectual disability because it affects our intellect and the way that we behave and the way that we relate to other people, just like intellectual disability does in other contexts. But some people with autism, this is where it's going to get really confusing. Some people who are on the autism spectrum also have an intellectual disability and others don't. Because in one sense, it's this big intellectual disability is a big umbrella term that we use. In another sense, it's a specific condition. So I was just using it as this big umbrella term, but now I'm going to use it as this very specific condition. I'm going to talk about it just in that way, okay? So if you're confused about this, know that I am too. My first professional job that I actually got hired on salary and I wasn't working hourly was at a community college in a program for students with intellectual disabilities who had aged out of the high school special education public process and were now at college learning entry-level skills to get their first job, something like that. And it was for intellectual disabilities, and I was like, okay, now somebody tell me what the definition is. What does this even mean? What are we talking here? Because I was seeing people who were, high functioning on the autism spectrum, people who had Down syndrome, people who had specific learning disorders, and I was like, okay, these all look very different to me. Tell me what intellectual disability actually means. And they were like, well, I don't know, and nobody knows. So I was like, well, how the heck do we even do this? So part of the reason that I was so confused, and that you might be confused too, is because we're talking about it in such different ways. So let's try and do our best to stop talking about it in this global sense, and now we'll get a sense of what it means to talk about intellectual disability as a condition, okay? With that said, now I'm going to tell you that we're going to include several different disorders or presentations, okay? Presentations meaning the way the clients show up to you and what it looks like in their lives. We're including Down syndrome and Fragile X. Those are specific chromosomal abnormalities, and we can look at that and say, well, this is missing genetics, something like that. But it's not only that. In some cases, we don't know the cause of why this happens. So when we're talking about why this happens, what is this? Well, this is a whole range of behaviors, but it's like diminished cognitive and physical capacity. Okay, so we'll get more into this in just a second. The one thing I think I should have mentioned already, but I forgot to, is that we used to use this term mental retardation. That was the term that was in the diagnostic manuals. That was the term that was in um, public discourse. Is we use the word retard to describe a specific condition. Over time, as it began to be used more often, it turned into this nasty, terrible, judgmental, pejorative term that people use to pass judgment on somebody else about how they were not enough or not good enough or something like that. And as a result, it became a dirty word and it sucks and we don't use that one anymore. So we use the term intellectual disability. This is part of why it's confusing. We use that term instead of mental retardation because that term is not okay anymore. And so when you're hearing both of these things, intellectual disability is a replacement for that word because it turned into something that's not okay anymore. So that's worth mentioning. But it's not just the chromosomal things. It could be as a result of a whole bunch of different issues. In utero chemical or prenatal chemical exposure, hypoxia or lack of oxygen. Could be a genetic thing, like I mentioned. It could be the result of an infection, a prenatal infection. There's just a bunch of stuff, and we're like, do we really even know where this comes from? Kinda, sometimes, you know? Other times we don't know. In terms of our counseling work, we don't have to care quite as much because that's up for, it tends to affect people who are more interested in public health, who are more interested in specific treatments to avoid those kind of situations. What we're doing is we're saying, okay, now you live this way, you have this condition, or you are this kind of person, whatever. And what do we love about you, and how can we help you be the best you can be? That's what we do in any condition, whether it's a mental health condition, physical condition, genetic, due to drugs, due to whatever, or even those of us who say, like, I don't really have a condition, so to speak, but I'm not the best person that I can be. That's kind of what counseling does. Can I help you find value and worth in your life? Can I help you build better relationships? Can I help you find work, etc.? So we're less concerned about the causes. That's the moral of the story here. And I know I keep saying that over and over again in all these different presentations, but it's worth repeating because it's so important. So when we're talking about intellectual disabilities, what used to happen is you give a person an intelligence test and you say something's going on here. And if they scored less than 70, you'd say, you have an intellectual disability. So go to that hospital and stay there for the rest of your life. We don't care if it's mild, moderate, severe, whatever. Go over there because that's where you belong. But now we're getting better, and we know that's not good enough, right? So we include this not just intellectual functioning as a result of a test. By the way, that led to a whole bunch of nasty consequences. And if you're in the counseling profession now and you're like, we don't trust those tests anymore, that's part of why. But that's a discussion for a different place or a different day. What we now consider part of the diagnostic criteria is deficits in adaptive functioning, meaning what we kind of deem as like developmentally appropriate benchmarks for most people, the kind of the normal benchmarks, or socially appropriate benchmarks, the way we interact with each other and kind of the rules of social engagement. For those of us who work outside of those, what is considered normal, we consider all of that stuff as well as intellectual capacity also, and those are both important here. When we talk about this as a very specific condition, there's a very specific way we look at that. It's really hard to describe what that is, and so you're not going to leave this presentation saying, oh, I know exactly what that means. You're going to have to go spend a bunch of time around people and just get experience interacting with people, getting trained from people who've done this for a long time, not me. I can tell you all the things I know, not in one presentation today, but even still, that's probably not good enough to make diagnoses like this. But those are the two sort of classification diagnostic criteria for intellectual disability. Now, if you look at the second bullet point here, what used to happen is we used to categorize it as mild, moderate, severe, and profound. And because of political advocacy, lots of development in the world of disability, particularly when it comes to intellectual disability, we've said, remember all that stuff about the assessment, how damaging that was to people and how people have been mistreated over time and how it's just misunderstanding the value of life? Well, let's give it a different classification. And what we came up with, or not we, make it sound like I had a part in this, what somebody came up with, You know what I'm trying to say? What, oh, this is going to bug me now. What had been developed, there we'll say that way. What had been developed was this list above here. Intermittent intellectual disability means you have short-term and periodic needs for support, which, by the way, if you were to think about that as kind of that mild category, that makes up 85 to 90% of all people with intellectual disability kind of fit in this category of like, you might from time to time need a little bit of extra support, but it doesn't mean you need somebody to live, you don't need to live in a group home with 24-hour care around the clock, something like that. Limited, low intensity or time limited supports for specific areas, or extensive ongoing low intensity supports at home or work. Those are the other two categories. Okay, so, but let's keep moving on here. We'll try to get a better idea of what these look like. Now we have to go back, because the textbook describes it this way, we have to go back and talk about what do these different old categories look like. And then we can go on and say, well, let's talk about strengths and talk about how we provide services and that kind of thing, which, by the way, we're not going to get to today, unfortunately, but this is kind of the situation we're in. This is the conundrum why I'm going to go kick things after I'm done with this, because I don't think I'm doing a very good job of this. But anyway, mild, when people are growing up, they might have an intellectual disability, but in some cases you'll know. Like if somebody has Down syndrome, you can do a test in utero for Down syndrome. You can do chromosomal DNA tests. And people with different conditions, Down syndrome, Fragile X, Williams syndrome, a variety of different ones, you can see in the way a person's features look, whether they have that condition or not. Sometimes you can visually see that, other times you can't. And so remember that 85 to 90% of people are in the mild category? Many of them are indistinguishable from peers. I might look like a completely normal kid and have an IQ of 65, and I might just look like I'm kind of lazy, or I just don't get it, or I'm just not applying myself, or all these other kind of things that you hear from people. But what we're talking about here is limitations in executive functioning, the ability to plan and organize, which, by the way, kids don't do a lot of that because parents do it for them, or school teachers do. Prioritizing. Cognitive flexibility means the ability to adapt to new situations, the ability to manage emotions, the ability to change when change is helpful or required. When we normally look at that and say, to be able to adapt means to change appropriately to the circumstances, but when people can't do that, that's what we're talking about here. And so it can just seem like people are just like, you're just an underperformer, and hey, there's winners and losers in every game, and you're just one of them. But that's misunderstanding something. It can also look like you're just being lazy and you don't get it. So as a result, people can be perceived as to not have a specific disability and just, lost the lottery of life. And there's this attitude of like, well, too bad, you fail, go be somebody else's problem. And that's where the real damage comes in. And that's where us as counselors get to come in and say, well, that sucks. That should have never happened. We don't want to think that way. We can do better. And so, but oftentimes sometimes you'll end up working with people with a mild intellectual disability and they don't even know they have one. Or parents don't look at it in a way that's really strengths-based and helpful, something like that. So that's where a lot of our work can come in. Moderate, slow academic process, less complex functioning. Again, to get a good picture of what that looks like, you'd want to spend some time with some people who have this condition. Severe, requires extensive support and understanding adult skills, and profound, often associated with other health conditions and often nonverbal. These are just like a few identifying characteristics, but definitely not the whole story. One thing to point out, though, is that anybody with an intellectual disability are seen as vulnerable in some capacity. Even if you're the kind of person who says, I have a mild intellectual disability, and I don't feel any different than my peers, and I have a family that loves me, and I have some friends, and I do all these kind of things, I still might miss some cues about what is safe and what's appropriate, and as a result, other people can take advantage of me because I depend on support so much to get through life. It's just like when I call customer service at the bank that I go to, there's a whole bunch of stuff about banking that I just don't understand, and I'm relying on other people, right? And I also rely on their integrity. meaning they could totally take advantage of me in certain cases, right? The more that I inform myself and the more that I understand about banking, the less likely they are to take advantage of me because I can see red flags when they come. Now, take a person who says, I just need to, I have a hard time counting money, but if I go to that cashier at the gas station and I say, I just paid for gas, here you go, here's the pile of money. If I trust their integrity, then they will help count it out for me. Unfortunately, we can't always trust people's integrity, right? And this is just one of the things of life. But for those of us who have a harder time doing more of that sort of adult stuff, quote unquote, we can be vulnerable to predatory behaviors. They can be sexual, financial, relational, and all kinds of other things. So just, that's what we're talking about here. Okay, hard stop. We're going to shift gears and talk about the autism spectrum. When we talk about the autism spectrum, this is one of those things that everybody's heard the word autism. Everybody knows, quote unquote, what it means, but it's probably much more complicated than what you think, because you might have even heard, excuse me, you might have even heard the term, well, if you've met one person with or the phrase, if you've met one person with autism, you've met one person with autism, meaning that everybody looks a little bit different, everybody acts a little bit different with different kinds of behaviors, but we're all on the spectrum. So what used to be 3 different diagnostic labels, autistic disorder, Asperger's syndrome, and pervasive developmental disability, or PDD for short, sometimes you'll see that in people's files and stuff, is now everybody falls along the same spectrum, somewhere between like high functioning and low functioning. And those terms are even a little bit odd when you start to look at the different ways that people present and live their lives and stuff. Without going too much into all those different ways that it shows up right now, one thing we can know is that it's 4 to 4.5 times more likely in boys than girls. That can be helpful to know. And then in terms of this spectrum, 44%. Oh, by the way, autism this is when I was getting back to that intellectual disability versus these other terms. Is it the umbrella term or is it the specific thing? When we talk about intellectual capacity or intellectual abilities, somebody might be on the autism spectrum but have average or above intelligence. And that's like 44% of the people who are diagnosed on the spectrum are in that camp. And so we're not saying that they have also an intellectual disability. 24% are sort of on that borderline range. And then when we talk about those who have autism and intellectual disability, that specific thing that we talked about earlier, that's 31% of the people on the spectrum also have an intellectual disability. So somebody could theoretically have a diagnosis of autism and mild intellectual disability, or autism and profound intellectual disability, or autism without any other diagnosis. That's totally possible, which is why this stuff gets so confusing, because of the range of different behaviors that can happen and the different categories of or diagnoses that are possible. This isn't all that unfamiliar, though, to us. For those of us who have worked in this sort of mental health counselor capacity before, or around that population, there's a fun fact. There's a 66% reliability between, or no, let me say this again. There's a 66% correlation between the Beck's depression inventory and the Beck's anxiety inventory, which means that if you have one condition, there's a 66% likelihood that you also have the other condition, or at least the symptoms overlap that much. There's an overlap in the symptoms. So when we say like autism, intellectual disability, and we're like, I don't know, what are the behaviors that overlap and stuff? If you look at those disabilities and looked into the specific criteria, you'd see some overlap also. And in some cases, that's that like 31% co-occurring, whatever. In some cases, they warrant both labels, in other cases not. Just like if you said you have depression but not anxiety. But in some cases you have both, and that's totally possible because of that overlap. And so it is confusing, it is messy, but when you spend time with this stuff, you start to get the impression of like, oh, I see what that looks like now. Somebody who's living with both conditions, these are the kind of things that they experience, that kind of thing. So what does it look like? I just wrote a list here that came out of one textbook, which I think is not an adequate list. There's more to be said about this, but again, this is going to be a completely inadequate list. Solitary behavior. Um, Enjoying being by themselves. This is not just like I'm an introvert and I can be around people, but then I fill my cup up when I spend time alone. It's not that. This is like I just don't I don't want to be around people ever. Like I'm kind of a loner, quote unquote. In terms of childhood abilities, lack of imaginative play, very literally minded, attachment to inanimate objects or toys and that kind of thing, rather than on people. This kind of looks like, I don't look my mom in the eye when eye contact is a very normal thing for babies. With the baby doesn't look mom in the eye, mom's like, oh my gosh, there's something wrong, and it's not necessarily wrong. I just have maybe autism isn't in their future. Could also be just lack of facial expression. Doesn't mean they're not registering other people's facial expressions, but it's just not something they might give back. So it could look like that too. In some cases, repetitive or stereotypic movement, so body rocking, hand flipping, hand flapping, finger flipping, biting. It could be a whole bunch of different range of behaviors, but those are kind of common ones. These are typically more on the I don't even know what the PC term is, to be honest. On the lower functioning, more severe side of the spectrum, these things are a little bit more common. The hypersensitivity to response to stimuli, it's kind of this one down here below. It's kind of related to this stuff a little bit. One guy that I knew, just for sake of example, he did a little bit of hand flapping. And he would be considered more on like the severe side of the autism spectrum in terms of limiting of functional capacity and all that kind of stuff. But he was super pumped about helicopters and fidget spinners. He just loved them, like absolutely loved them. So he didn't do a lot of hand flapping or body rocking or anything like that, but he was constantly doing this with his fidget spinner and constantly like playing with rotating objects. It's just like for him it was like, oh, this feels so good. That kind of thing. It's like eating ice cream. I don't even like ice cream. What would be an example? I love it when my wife pinches my neck right here. And I'm just like, you touch me like that, it makes me so happy. That's how it is kind of with him, only it's like the movement of the thing. Difficulty with changes in routine, especially with what used to be called Asperger's, can get very rigid and organized. When we talk about being organized and structured and planned and oriented that way, there is that sense, but it can also be if somebody is living also with an intellectual disability and is not that way, is not very good at planning and organizing and being structured and all that kind of stuff, there still can be this sense of like, change is hard. Even if I can't plan it, if I had some semblance of an idea of what I wanted or what was supposed to happen and that changes, that can still be a really difficult thing. So this is why it gets so hard. It's because one person can be rigid and the other person can look like they have no organization in their life, and both people can be thrown completely amiss by things changing, deviating from what is considered normal. So this is what makes this such a difficult condition to diagnose. Part of it. Inability to decipher verbal or nonverbal cues. So again, this kind of goes back a little bit to like, imagine the baby looking at facial expression and just being like, I don't know, why do your lips move up sometimes and down other times, happy and sad? Like, just, what does that even mean? That can be confusing. And then difficulty expressing needs orally, or somebody could be highly verbal. In other words, it's not just about expressing needs. Sometimes that's that, but also it could be just like getting the words out. Like, I just don't even know, They're like, It's not just about not having the language for it, because somebody might have the language for it, but just can't get the thing out, even if they know, which is where you'll hear people talk about autism as like, these people are smart, but it doesn't look like it. But they are, but you're just not asking the right questions, or you're not giving them an opportunity to express it in a way that makes sense to them, or something like that. That's kind of what we're talking here. I'm trying to give the flavor of like, just because a person doesn't say it or looks like they're struggling, it doesn't mean they're repressing trauma. which we talk about a lot in the mental health world. Somebody is like, I know I've been sexually abused, but I can't, I'm so ashamed of it that I can't talk about it, or I have an addiction that I'm afraid of judgment or something. It can look the same on the outside, but it's coming from a completely different place. I know I want to talk about it. I know I can share it with somebody. I don't even have the concern about what you might think of me because that social stuff is missing, you know? I could care less if I told you, but it just doesn't come. Something like that. On the flip side, you can have somebody who's like highly verbal, who's always talking, blah, 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 you know, kind of like I do, very fast. You know, blah, 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 blah. Also, this thing called echolalia, which is like repetitive mimicking of sounds or words or something like that. If you ever had anybody who you're talking to in conversation, counselors do this by training a lot, where we repeat words that we want to emphasize in a person's statement. It's like someone says like, oh, I'm feeling very sad today. And I just, you know, I came from, oh, sad. Tell me about that sad, you know, repeating things like that to emphasize. It's kind of like that, only you know, I'll tell a story about how like, oh, I went to the store the other day to pick up some candles for my wife. It's Valentine's Day today when I'm recording this. So I got a card and all that kind of, which reminds me, I have to go do that after this. And if that person said card, candle, you know, and does that kind of repetitive thing, it might not just be one repetitive one word repetition, but like candle, 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 candle. It could be that too. So this can really look a lot of different ways depending on who the person is and where they are and that kind of thing. Okay, I'm going too slow. How much time do we got? 26. All right. As far as the causes, nobody knows. You've heard of the controversy probably about vaccines. I mean, there's all kinds of people trying to understand or learn about what likely causes are. And there was that one garbage study that was later turned out to be misreported and unethical, and it's not good science. But for whatever reason, it caught on and people used it as like, well, vaccines are doing it. And we've been trying to make up for it ever since. This has nothing to do with whether vaccines are a good thing or not, but they don't cause autism. That's what we think now anyway. That's the best science that we have, is not that vaccines have anything to do with it. There may, in the future, you know, 50 years, we might come back to find out that, oh, actually they do, but for very different reasons than we thought. The thing to emphasize now is the best science we have going is that vaccines were not the cause the way that one study said they were. So that's just the important thing to know here. So how do we know what autism is, what it looks like, and how do we diagnose this? Well, the point is that it's hard. It's really hard to do. Because if you're sitting there thinking, it could be this, it could be that, it could be this other thing, it could be something else, we don't really even know. We don't know where it comes from. We hardly know what it looks like. Well, it's hard, but it's possible. And we have some ways to outline it using the behavior that we talked about a little bit before. The reason we think it's important to identify it is because then it's important to it helps us understand it differently. Just like when I was talking about how it's hard to get the words out, sometimes it's because of shame, and other times it's not because of shame at all. But if we look at it one way or the other, it can change the way that we treat that, the way that we deal with it. You know what I mean? If you talk to somebody with autism and you're like, I know this is hard for you because I know how shame works, and if you know, you can trust me. And they're like, I don't distrust you. I don't know what you're talking about. What's this shame business? You know what I mean? You're gonna miss, and it's gonna feel kind of like, wait a minute, I don't know what I said there that was not right, or whatever. It's because you're treating the wrong condition. That's the point. So you will have to have some solid experience in a range of presentations of the way people are, and that's just sort of the nature of it. So if you're thinking like, I want to specialize and I really want to understand autism and know autism, my brother has it, my son has it, my ex-wife had it, whatever it is, you've seen a small glimpse of it, and there's more to it. So just understand that, like, it's one of those complicated things that you should be very careful if you're saying, this is sort of autistic-like behavior that I'm noticing. That's okay, you can have your suspicions, but it's really important not to jump to a conclusion about this. Testing requires training experience, obviously. The hallmarks of ASD are social disabilities, typically. One of the things you didn't see earlier was this talk about like lack of empathy. Sometimes we talk about lack of empathy when it comes to sociopathy or psychopathy or some of those like personality disorders, narcissistic personality disorders, and that kind of stuff. And that's a very, very, very different thing than the inability to empathize by somebody who's on the spectrum because of the way that it shows up. In one case, it might be criminal, in the other case, it might be innocent. And they're very important to understand the differences. But you'll hear people talk about lack of empathy. It's the way that it might show up with somebody on the spectrum. It might be like, your zipper's down today. And in some situations, it might be like, hey, Joe, I just want to let you know that your zipper's down so you don't feel awkward later on, you know? Like, we're sensitive to the other people and the way they might react to it. And the person on the spectrum might just be like, it's a fact. Facts require honesty, and I'm going to be honest with you, your zipper's down right now. And then they move on. And the other person's like, that was kind of abrupt, right? I'm glad you did it, but you could have done it differently. Something like that. It's that kind of lack of empathy that just leads to the sort of social awkwardness. That's why we talk about sort of social disability. It doesn't, what the difference is between that and like this sociopathy kind of stuff is that his zipper's down and I'm going to find a way to use it to meet my needs. And that's a very different thing than just to say like, fact, your zipper is down, right? So that's a little bit about the difference. The book talks a little bit about personal space. That's just sort of lack of understanding personal bubbles and social acceptability, that kind of stuff. And then rigid behavior, we all kind of talked about that thing. Talked about that already. It also can look a little bit like OCD, kind of. When we talk about repetitive movements of the body, we can also talk about repetitive routines, which can look like OCD and sometimes show up that way, but not be OCD. And so the more you start to understand OCD, which is an anxiety-based repetition, and autism spectrum disorders, which are not anxiety-based. They're just rigid and rule-oriented, but have nothing to do with fear or stress or nervousness or anything like that. You'll start to see the differences, and there are differences, but they're complicated to describe and explain. So, and I can't think of a good example right now, but sometimes you'll see the outside behavior coming from a very different place. So I just thought it was worth mentioning that. Communication difficulties, there's a wide range of styles of communication. We talked about echolalia before, and we talked about there are people who are nonverbal who don't talk at all. Some people who talk in only abbreviated sentences. Some people that are incredibly brutally honest about everything, and other people who just choose not to say anything because they don't want to hurt other people. So like just a wide range of communication styles. So different. The other thing the book talks about in terms of, it has nothing to do with cause and identification, so it's maybe a little out of place, but they talk about how somebody can, because of the unique nature of the disability, if you grow up in a family that understands you, but then there's these milestones throughout life, and ending school, transitioning out of school is one of those milestones. Leaving the home is another one. Building a family is another one. Like there's all these different milestones. Getting a car. When those things happen, that person then participates in another social group, a different kind of group of people who potentially can misunderstand or not know them, as well as their immediate family. And those are really crucial times. But leaving high school is one of the really big ones where people can totally, they call it like falling off a cliff, totally feel like I've just gone to a different planet and it just feels so different. And that can be a really vulnerable place for people too. Okay, another hard stop, shift gears here. It's not shift gears. We're just like turning into a different, on a map. I'm gonna milk this driving analogy here. You're not shifting gears because we're not slowing down or speeding up. I need to find a new way to talk about this because that analogy just doesn't make any sense all of a sudden to me. We are going to go from one topic to the next. So we're going to get off the dirt road and onto a paved road. Or I don't know what I'm saying. Change topics. Attention deficit hyperactivity disorder, ADHD. Another one that everybody's heard of. We're not going to talk about the specific diagnostic criteria because it's a little bit complicated. We have to really get into the weeds of executive functions and what those mean. There's a list, for those of you following along in the book, there's a list of diagnostic criteria. You can find it in the DSM. I'm sure Google knows everything and you can find it online too. But be careful. I should say that. Symptoms must present before age 12, and they must happen in more than one environmental situation. Part of the reason for that is because sometimes the behaviors that come along with ADHD, either primary as a result of the attention disorders or hyperactivity disorders, or as a result of the conduct learned from having that condition. These things can look like attachment disorders, and they can look like other things that aren't biologically rooted in brain functioning. And so that's why it's really important to get adequate testing. And it has to be in more than one environment. And it can't just be like, the teacher said I'm hyperactive in school. Well, maybe it's because this person's highly intellectually capable and they're just bored. Or maybe the teacher is, unknowingly being rude to this person. They think everything's fine, but the kid's just reacting to bad relationships, kind of thing. So it has to be pervasive throughout life. That's the point. Twice as many males and females. Related to that other point, I was just making, an assessment must be thorough and triangulated. In other words, from multiple sources. So parents, teachers, extended family, whatever, wherever this person's interacting in these different environments, you take into consideration that kind of stuff. 9 symptoms related to attention, 9 related to hyperactivity. So there is attention deficit disorder, ADD, and that's different from attention deficit hyperactivity disorder, ADHD. And so that's an important distinction to understand. As a result, and we'll get a little bit more of the flavor of ADHD, but as a result of the ADHD, the way it shows up in a person and the way other people react to that hyperactivity and attention disorder, it can come along with mood and anxiety disorders. Substance use disorders are common. Conduct disorders, oppositional defiant disorder, ODD, specific learning disorders, which we talked about in the intellectual disability chapter. Or no, that's coming up next, actually. Motor disorders and autism spectrum disorders. These can be kind of co-occurring things that happen relatively commonly. As far as treatments go, medication is the most common, and they can be both stimulant and non-stimulant. And if we had a whole bunch of time, I would talk about the differences between both and the consequences of that too. What it's like for a person with ADHD to go into a social environment in high school and then, start selling their drugs to their friends and that kind of stuff. Like, all these things are part of this conversation. It might be that they're abusing drugs not by taking them themselves, but by giving them to somebody else. It might be that they find that meth is more fun for them and it stimulates their need to be impulsive. And there's all kinds of reasons why, a person, the way this is shows up in their life, something like that. So you might be getting the picture already that it comes with an increased risk for school issues, both truancy and failure. At least that's what the book says. I can imagine social identity issues in high school and the way people treat each other, whether they're very social, whether they're athletic. People with ADHD live in all different social groups and all different socioeconomic statuses and all that kind of stuff. But it increases the risk for some of these things. Addictions, already mentioned that, and antisocial behaviors, usually related to, the way they're treated by other people, that builds these trust issues with them, or frustration or anger with a certain kind of people or a certain group or authority or whatever it is. So it leads to some of that too. Increased risk for accident and injury is a big one. Impulsivity is a part of that hyperactivity and attention disorder. And so the need for cognitive stimulation and stimulation in life, but also social gratification, and that's not the word that I'm thinking of, but social approval or something like that, can lead to impulsivity and sort of risk-taking behaviors, that kind of thing. Associated with poor job performance, work attendance, conflict with supervisors. Well, no crap, you can imagine, right? If people are treating me that way, and I'm having a hard time focusing, sitting down at school, and my brain's all over the place. Like, we've probably all had times where we've just been like, I cannot focus. I can't do it right now. Imagine that all the time, and then having somebody say, just sit still. Come on, like that kind of thing. And then you say like, no, leave me alone. Don't pressure me so much. And then they're like, well, poor evaluation. You can imagine that, right? Um, Others can perceive it as a result of this condition, it can be perceived as lazy and unreliable. It's really fun hearing stories of people who are like, once they find the right medication or once they find the right social supports, how different their experience of themselves and the experience of other people of them, and how well they can like function a little bit better as a result of the treatment, and how differently that looks from both the inside and the outside. It's amazing. Um, uh, as you can imagine, the way we've been talking about this, the above stuff can lead to an understandable decrease in self-esteem or self-concept, negative beliefs about the world. Um, when it comes to like teachers and school administrators, people are constantly yelling at you to pay attention, and you don't pay attention, and then you find out it's more fun to talk to your neighbor, and your neighbor is a bad influence, and then you start getting into other things. When I was in high school, you might not be able to tell now because all this stuff, but I hung around with all the skaters and the stoners, and well, it was mostly junior high, but I hung around with the skaters and the stoners and the people who were like, doing cocaine in ninth grade and that kind of thing. And I didn't do a ton of that stuff, but like I was around that crowd, and I learned a healthy distrust of authority because I knew that even though I wasn't involved in it, I was guilt by association. So I learned a good, healthy fear of authority. Well, I shouldn't say healthy. I learned a fear of authority that was not helpful to me. And that was a result of just like, I mean, it had nothing to do with ADHD. I don't have that diagnosis, but you can imagine how that would change my view of the world and who I trust based on the experiences of who I was around and all that kind of thing. Anyway, you guys all have your stories, I'm sure. So we don't need to belabor this point. Risky sexual behaviors are also included in this list as well. Okay, last shift, not shift gears, last shift to a new topic. We're going to talk about specific learning disorders. These can be categorized as mild, moderate, or severe. And the important thing to understand about this is that whereas intellectual disabilities are related to some of these similar things of cognitive functioning, specific learning disabilities or disorders are called specific because it's related to one specific area, and it may not be a reflection of intelligence. So somebody can be completely smart and not be able to do a specific task. And here's what those tasks typically are. They kind of fall into two categories. There's more than this, but like this is how we can think about it to understand the surface level. Dyslexia, which is something that most people have heard of because it's relatively common and kind of popular parlance for us, is an impairment in reading accuracy, fluency, and comprehension. Sometimes you'll talk to people who see letters backwards or see words that mix up. I don't know that we'll talk about it this year, I don't even know if I've seen it in the textbook yet, but there's this experience called synesthesia, where people will sometimes experience a word as a color, or they'll hear the taste of something, and it's sort of like your sensory experience is sort of swapping over into other areas, It's not like that because this is just relating to language, but it's kind of like that where somebody could say, see the letter F, but processes it as the letter M, and then just get really confused. So you're reading along, and all of a sudden you're like, you see the word forward, and every time you look at it, it looks like the word moreward, and you're like, that's not what people say. Moreward, what the hell is that? You know what I mean? And so it could just be like, it just takes longer to like learn that F means, or M means F in some cases, and so that's why just specifically to language. Okay, enough said. I've been talking for too long today. Dyscalculia. This one is hard word to say, but it relates to math. And same kind of thing. Difficulty understanding number relationships, math facts, and math reasoning, that kind of thing. Okay, also, kind of like ADHD, it can often look like a person just has lack of interest. But when you're reading a book and none of it makes any sense, you're going to lose interest really fast, obviously, right? But it's not that they don't care about the story and care about the meaning of it and how it what it's telling us. It's that lose interest because it doesn't make any sense when I read it. So it can look like that, or it can look like somebody's being lazy, or they're just not smart, or something like that. Whereas the person has complete understanding of the words, the comprehension of the sentences, they can understand the meaning if told to them, or if read out loud, or somebody read it to them. But to read it themselves, it doesn't comprehend because it doesn't make any sense. So it can look like a person's underperforming because they're not intelligent when it has really nothing to do with intelligence. Identification from intelligence testing and psychosocial evaluation. And again, this is one of those areas where you can't just look at the results of one test, but also sort of understand the context in the whole area of a person's life to understand how does this manifest in other secondary behaviors. Is it a result of something like, something going on at the home, or is it just a cognitive processing thing? The book mentions this, and I think this is probably true of other disabilities too. It's probably not just this one, but in this chapter it was brought up that the difficulty with managing either of these conditions or any of the SLDs has a lot to do with socioeconomic status. In the book, they mentioned that if a person comes from an affluent neighborhood where lots of resources are present, and also if somebody identifies that it's a disorder, provide the right treatments, either that person can make improvements or the community can understand what's going on and consider it a legitimate thing and not make fun of them, and then not lead to all these secondary things like emotional consequences like self-esteem. You don't experience as many failures when you know it's just the F and the M getting mixed up, or like, I don't do math because my brain won't let it happen, so I need to go do it a different way, right? And I won't get made fun of by my teacher for doing it a different way that works for me, something like that. So as a result of affluence, people can experience disabilities differently. And I don't think when I say it that way, it's that hard to understand. But when I read it, I was like, oh yeah, obviously, of course. But it's one of those things that it's so hard to understand how that actually plays out in real life. So that's worth a discussion in and of itself too, which we don't have time to have. Last slide. Right? This is the last one? Yeah, this is the last one. General neurodevelopmental issues. So when we're talking, this is like our recap section. When we're talking about all of these issues, there is this condition which is important to mention. It's called diagnostic overshadowing. And what that means is that if we attribute whatever issue that a person has in their life as a result of their primary health condition rather than a mental health problem, that can be really problematic. In other words, well, of course this person is mad. It's because they're stupid and they can't get it, right? Like, that's not an okay thing to say, but it's saying they don't have the intellectual capacity to deal with their emotions properly, when in fact they probably could, right? We need to treat it differently. We need to talk to them differently. We need to process emotions differently. But that person may have the complete capacity to process an emotion, even though they may not understand the source. Just for sake of example, there's a ton of stuff that I don't understand about why bad things happen to good people. But that doesn't mean I can't cope with it, right? Just because my tiny little brain doesn't have the capacity to do all the things that all of you smart people can do doesn't mean that I can't feel better about my life and still make meaning out of it. This is what we're talking about here when we talk about diagnostic overshadowing. You would say, oh, well, because this guy's an academic, of course he doesn't understand what real life is all about, right? Which is kind of not true, but it's using a part of my identity to explain another part that has nothing to do with it. That's what we're talking about here. So just a few examples on the screen. It's the autism that makes him angry, not the way we're treating him. So is it a person who's frustrated because they can't communicate? Is it because of their lack of communication and therefore that's why they're just angry and they're always going to be angry? Or is it because the rest of the world treats them like assholes? Or they're being assholes by treating that person as if they're just not worth talking to, when in fact if somebody sat down with them, took the time to listen to what they were trying to say, and then say, oh, you're just like, this is what you want out of life and this is what you want to do. And then all of a sudden the person's happier, right? Because you address what their need is and you understand that it's not about their problem of communication, but my problem of listening. then these things kind of sort themselves out. Another example is she just upset because she doesn't understand, or is she depressed because she doesn't feel understood? So that one takes a little bit of unpacking, but does she not have the capacity to make sense of this thing and therefore is sad because of it? Or is it my problem that I'm not giving her the time to actually listen to her, to understand what she wants to communicate to me and has a need and it's not being met? And if I could just understand it, I could meet that need easily and she wouldn't be so sad, right? So in other words, where's the problem? It kind of harkens back to that medical model and social model stuff that we talked about very early in the like chapter 1, I think, where is the problem inside the individual as part of their condition, or is it the way the world treats them? Is it a social problem? It kind of relates to that kind of thing. Another problem is totally unrelated to what we're talking about, but most people feel like this, talking counselors and parents and doctors and all that kind of stuff. Most people feel untrained or unequipped, and so they don't even try. In other words, I could probably, if I sat down and talked to this person, I could meet their needs. Take, for example, somebody with cerebral palsy. I kind of used an example earlier. I talk like this, and it's hard for me to communicate the things that I'm trying to say to you, but I really know what I'm trying to say to you. But for some of you, you might think, like, that's really hard to understand. I don't know what the words are exactly, and I can kind of make out some of them. If you sat down and talked to me, and that was my way of communicating, and I was trying to say to you, you know, I really would like to hang out with you sometime, and it would be really great if we could, like, play a game, right? And you're like, I don't know. Okay, I get and you walk off and you don't even give the time of day. You could easily be like, yeah, I want to play games. I love games, right? But if you feel like I don't have the training or understanding to deal with this, I don't know what to do, and I'm so nervous, then we run into the problem of not really listening to that person's needs, which is what the mental health concern is. Or as a result of crappy situations like that, the person feels sad and isolated and kind of depressed or maybe anxious about going into new social situations, and we're like, I don't really know how to deal with that. But if we can start to see as clinicians, as counselors, if we can start to look at people and say, what are your basic needs? What do all people really need? Well, they want to be appreciated, for one, and they want to be listened to, and people want to feel like they're being heard and understood. And even if it takes a little bit longer and it's a little bit of a struggle, if we as counselors say, nah, I can't do it, that's going to create more problems, right? So the challenge I have for you is to say, even if you feel like you're unequipped, even if you feel like you don't get it, if you're undertrained, well, a lot of us feel pretty unsatisfactory or inadequate at times. But these are situations where it happens more often, and it leads to detrimental results of other human beings who just, want to be with other people and have their basic needs met. Related to that, most, and I put in parentheses is my term, but don't all people want to have a home, a safe place? Not just home, but like where the heart is, like a safe place to live where you can feel comfortable and not like you're under pressure, where you're not afraid of certain people and that kind of thing. Belongingness. By the way, I started my career with disability in group homes, and this was a thing that I was always like really uncomfortable with, because group homes at times, not always, I've been in really good ones, but at times they can feel like, you have like all of your charts on the wall, and you have your, medication room that nobody's allowed to go in. And like, this is really hospital-like feel to a home, even though it has lazy boy chairs in it. It still feels like there are all these rules and all these part of the system, and it just doesn't feel like a safe place. And there's all these people coming in and out, and they're different all the time, and there's staff changes and all that stuff. It's not home, and so that's something that I was a little more sensitive to, and I still am, kind of, obviously. I think it's probably pretty obvious. Home belongingness, the ability to grow and also to learn, and then having attachment, intimacy. The book talks again about sexuality, and we've talked enough about that for now, but it's worth pointing out that that's what we're talking about also. People have sexual needs, even if they don't really know what to do with them or how to do them appropriately, or who to touch and how to feel about other people and all that kind of stuff. we all need education, even if it takes us longer. Same kind of theme. And then families, this is a big one, which we should talk about more, but we're not going to today. Families need support to manage changing expectations and increased needs. And that relates a little bit back to what I was talking about, helicopter parents and neglectful parents, and that kind of thing. Families need to understand, what do I need to specifically be doing? Where can I let go? How do I manage my own expectations of I was going to play ball with my kid when he got older and now I can't, and all this kind of stuff. Lots of space for family support and counseling when it comes to disability, not just for the person with the disability, but other people as well. Okay, I'm done, and that went way longer than I thought it would or should. But if you're still with me, thanks for hanging on, and I will talk to you again later. See ya.